Hi, my name is Marisa Clark, and I am a current graduate student in the Master of Science in Health Informatics program at George Mason University. This presentation details my capstone project on improving kidney health quality measure scores through enhanced interoperability. Thank you for taking the time to watch. Lexington Medical Center is currently facing challenges in capturing estimated glomerular filtration rate lab value results from outside sources within their electronic health record system. The system limitation encumbers the ability to compile and accurately report data necessary for meeting the Electronic Clinical Quality Measure CMS 951V2 as required by the Centers for Medicare and Medicaid Services. CMS 951V2 focuses on kidney health in diabetic patients and requires that patients aged 18 to 75 years old with a diagnosis of diabetes receive a kidney health evaluation. Patients with a diagnosis of end-stage renal disease, chronic kidney disease stage 5, and patients on hospice or palliative care are excluded from this measure. To meet the evaluation criteria, two critical lab values must be documented: the estimated glomerular filtration rate and a urine albumin creatinine ratio. Currently, LMC has successfully mapped the UACR and can utilize results from external facilities to receive credit for that portion of the kidney health evaluation measure. However, the Comprehensive Metabolic Panel, or CMP, which contains the eGFR value, is not yet mapped. The primary objective of this project is to enhance provider performance scores for kidney health evaluation by mapping the CMP to capture the eGFR results from the external facilities. By incorporating these external eGFR results, we aim to achieve a 5% increase in provider performance scores. During a recent meeting with the EHR vendor, representatives informed LMC stakeholders that the capability to automatically capture eGFR values without manual CMP mapping will be available by the end of 2025 at the earliest. This project will act as an interim solution until the EHR enhancement is implemented. By mapping the CMP to capture the eGFR results from external facilities, LMC will be able to meet CMS Electronic Clinical Quality Measure requirements, thereby ensuring compliance with reimbursement criteria. There are limitations to accomplish the eGFR mapping. The first limitation to consider is the timeline to complete the mapping. This report is part of HAP 790, Capstone Practicum in Health Informatics, the final course in the Master of Science in Health Informatics program through George Mason University, and is required to receive the master's degree. LMC has a different timeline to go live with the eGFR mapping, which is more forgiving than the GMU course deadline. Addressing this limitation will be discussed later in this report. Another limitation of this project is that the eGFR results are within the CMP. To capture these results, all components of the CMP must be mapped and standardized. Facilities report different components in their CMPs with varying units of measurement and ranges. Mapping the variances in CMP components is a very time-consuming but necessary requirement to capture eGFR results. Additionally, LMC currently has a non-disclosure agreement in place with their electronic health record vendor. This means the EHR cannot be mentioned by name in this report and that no data visualizations or images from the platform can be used. To address this limitation, internal data from LMC was compiled and manually entered into statistical software and visualization tools such as Excel and Tableau. By resolving the issue of capturing outside eGFR values, LMC will enhance its ability to provide comprehensive care, adhere to regulatory standards, and ultimately reduce the burden of chronic kidney disease-related complications. This, in turn, will improve performance metrics, support better patient outcomes, and align with the national health goals, thereby demonstrating substantial value to LMC. Addressing this issue is crucial not only for regulatory compliance, but also for improving patient outcomes. According to the National Kidney Association, approximately 37 million United States adults have chronic kidney disease, with about 90% of these individuals unaware they have it. Left undiagnosed and untreated, chronic kidney disease can progress to kidney failure and is associated with an increased risk of cardiovascular disease and death. In addition to meeting regulatory guidelines such as MIPS, where physicians are scored on performance categories which affects their Medicare Part B payment adjustments, enhanced renal health awareness and management aligns with broader health initiatives such as Healthy People 2030. One of the initiative's objectives is to increase the proportion of adults with chronic kidney disease who know their condition. A greater awareness of kidney health will lead to early identification and intervention, thus improving overall health outcomes. Given that diabetes is one of the most common risk factors of chronic kidney disease, conducting annual kidney health evaluations in diabetic patients facilitates increased renal health awareness. Data interoperability is crucial for integrating and utilizing patient information from various sources. The Health Information and Management Systems Society, or HIMSS, defines interoperability as the ability of different information systems to communicate and exchange data accurately, effectively, and consistently. Studies show that lack of interoperability can lead to incomplete patient records, hindering quality care and compliance with regulatory measures. In LMC's case, the inability to map eGFR values from external sources exemplifies these interoperability issues. The first step in this project involved gathering and evaluating the current provider metrics for CMS 951B2 kidney health evaluation. This evaluation is crucial for understanding and improving kidney health management among diabetic patients. For the preliminary analysis, we selected the top 25 providers who had the most patients meeting the kidney health evaluation requirements. These requirements included a diagnosis of diabetes without having end-stage renal disease, chronic kidney disease stage 5, or being in hospice or palliative care. To ensure privacy, the providers were de-identified and assigned numbers, protecting both the providers' and patients' privacy. Per CMS 951B2, the formula to calculate provider performance in this measure is to divide the numerator, which is the number of patients who have a kidney evaluation performed during the measurement period, by the denominator, which is the number of patients with an active diagnosis of diabetes who had an office visit during the measurement period, excluding those with end-stage renal disease, chronic kidney disease stage 5, or those in hospice or palliative care. We created an Excel spreadsheet containing data on each of the top 25 providers to assist in calculating performance scores. First, we collected data on the number of patients they saw during the measurement period with an active diagnosis of diabetes, setting this as the IPP, or initial patient population. We also collected data on the number of these patients who met the kidney health evaluation requirements, setting this as the numerator. Additionally, we recorded the number of patients who met the exclusion criteria, labeling this as the exclusion column. The denominator column was then calculated by subtracting the patients with exclusions from the IPP. Provider performance scores were calculated using the formula detailed above. Details of performance analysis will be discussed later in this presentation. As mentioned previously, the project timeline is a significant limitation in mapping of the CMP. Therefore, it was decided that we would map the CMP from the outside organization that exchanges the most records with LMC, as a larger volume of data would have a greater impact on provider performance scores. The two organizations that exchange the most records with LMC are Prisma Health and the Medical University of South Carolina. As of July 9, 2024, LMC has received 728,422,000 records from Prisma since January 1st of this year, and has received 339,965 records from MUSC over the same time. All-time records exchanged between LMC and Prisma totals over 11 million records, while all-times record exchange between LMC and MUSC totals over 3 million records. While both systems exchange high volumes of records with LMC, we decided to focus our CMP mapping efforts on records received from Prisma Health, as they ultimately exchange the most records with LMC and should provide the largest impact on improving physician performance scores. Once we decided to first map CMPs from Prisma Health, we began collecting data on CMPs sent from various Prisma Health facilities. We created a spreadsheet in Excel to compile the different components found in these CMPs. Since the components of the CMPs are not standardized, we paid close attention to the component names, LOINC codes, units of measurement ranges, and specimen types during the data compilation process. This meticulous task was time-consuming, and by the end we documented 265 variations in component measurements. The image below on the left is just an example of components you may find within a CMP, while the image on the right shows all of the variations in the eGFR labs received from Prisma Health. Following the identification and documentation of the variances, we passed this information on to a lab analyst to begin building the mapping within the EHR build environment. This step was time-consuming and further delayed by ongoing EHR updates at LMC. Ideally, the mapping would be built and then advanced to the testing environment and then moved to production. However, due to the significant EHR updates, it became clear that the CMP mapping would not go live by the project deadline. To address this limitation, we developed projected provider performance scores. We randomly selected 4 providers from the top 25 list and adjusted the numerator, or patients that have met the kidney health evaluation requirement. We evaluated the original denominator patient populations and identified patients with records from Prisma Health, who were then added to the numerator. This projection assumes that, since the CMP mapping has not been yet completed, patients with records from Prisma Health were not previously counted in the numerator. Detailed analysis of this projected provider performance scores will be discussed in the analysis section of this report. An initial statistical descriptive analysis of the top 25 providers revealed an average provider performance score of 29.5%, with scores ranging from a low of 15.3% to a high of 56.2%. The majority of providers, 44%, had a performance scores between 21 and 29%, while 20% scored below 30 to 39%, and another 20% scored between 40 and 49%. 8% of providers scored between 0 and 20%, and another 8% of providers scored above 50%. To calculate projected provider performance scores following CMP mapping, we randomly selected 4 providers and retrieved data from the original patient denominator populations. We specifically counted the number of patients that each provider cared for who had records from Prisma Health and added these patients to their provider numerator population. The selection of 4 providers instead of all the top 25 providers was again due to timeline limitations. The 4 random providers we chose were providers 1, 13, 14, and 25. Provider 1 had 143 patients added to their numerator population. Provider 13 had 44 patients added to their numerator population. Provider 14 had 65 patients added to their numerator population, and Provider 25 had 71 patients added to their numerator population. Adjusting the numerators to reflect the additional Prisma Health patients resulted in an increase in performance scores for each of the 4 providers. Provider 1 had an increase in performance scores from 33.4% to 48.1%, reflecting an absolute increase of 14.7 percentage points, which is an overall improvement of 44%. Provider 13 saw their performance score increase from 27.6% to 36.5%, an increase of 8.9 percentage points, and an overall 32.2% improvement. Provider 14 also saw an increase in their performance score from 15.3% to 29.1%, reflecting an absolute increase of 13.8 percentage points and an overall 90.2% improvement. Provider 25 also had an increase in their performance score from 20.5% to 37.3%, which is an absolute increase of 16.8 percentage points and an overall 82% improvement. Following comparative analysis, a paired t-test was conducted to determine whether there was a statistically significant difference between provider performance scores before and after the CMP mapping. The paired t-test, which is appropriate for comparing 2 related samples, revealed a t-statistics of 8.10 and a p-value of 0.004. With the significance level set at alpha equals 0.08, the p-value is below this threshold. Therefore, we can conclude that there is a statistically significant improvement in performance scores after the CMP mapping. Based on our comparative analysis and paired t-test results, we can conclude that mapping the CMP appears to have had a significant positive impact on provider performance metrics, suggesting its effectiveness in enhancing provider performance. Therefore, it is recommended that LMC continue with the CMP mapping of Prisma Health records. Once this is complete, LMC should extend CMP mapping to include records from MUSC, which is the second largest source of exchange records with LMC. Additionally, it is advisable to continue mapping CMPs from other outside facilities beyond Prisma Health and MUSC until the end of 2025, when the EHR enhancement that will enable automatic data capture is expected to become available. Adhering to these recommendations will enable LMC to fully leverage the benefits of CMP mapping by enhancing interoperability, further optimizing provider performance, and improving patient care. Here are the references for this presentation. Thank you for watching.